Welcome everybody to our fourth master class with Lisa Ferrara, and we have a really interesting topic today. It's motion preserving implants 20 years after Charite. Those of us like Lisa who were there at the very beginning, it's been fascinating to watch the development of total disc arthroplasty since Charite was introduced. And incidentally, as most people know, Charite is no longer on the market. But a lot has happened. We've learned a lot. New iterations have come to market, and it seems as though this is the right time to do a retrospective, and there's nobody better than our good friend, Dr. Lisa Ferrara. Lisa, welcome to 20 years after Charite.
Well, thank you again for inviting me 20 years later, knowing that I was around.
Now, in
For the
those days, my
beginning.
hair was longer. I had a ponytail. Things have changed.
I know.
Anyway, so we had a lot of responses to our topic, motion preservation implants. And I was thinking, Lisa, we'd get started with kind of an overview question, again, after 20 years of motion preservation, especially with regards to the artificial disc. Where are we, do you think, with respect to this revolutionary technology from 20 years ago, not so revolutionary today? Where are we now?
Well, the great part about this 20 years later, I was taller back then too, just so you know. Is that we've got a lot of data, a lot of really good clinical data out there that's been followed up for 20 years. And it's very positive in many ways. There's been a lot of technologies that have been approved, mainly in cervical. So I compiled from the FDA PMA site the cervical TDRs that have been approved and the dates of the first approval for each one, and then the lumbar. And so what you see is you've got about 12 cervicals and then 3 lumbar. Now, some of these cervicals, when you get into that site, they've got numerous iterations and changes. But what's very interesting is obviously the cervical is taken off for both 1 and 2 levels, certain ones that have asterisks, and there may be a couple more that I might have missed. My apologies. I believe ProDisc maybe 2 levels. The ones with the asterisks are also approved not only for single but also 2-level approval. Lumbar TDRs are not approved for 2-level, they're single level. But obviously there's a lot of activity with cervical TDR development, or there was. The most recent approval was the Simplify cervical disc, and we'll get into this a little bit more. But what's very, very, very interesting is that we're starting to address the patient's anatomy and even the biomechanics, and that's what we're seeing. So when you look at the traditional early discs, such as Prestige, Brian has been taken off the market, I believe. I may be wrong on that, but
I think you're right.
I thought they had, but that ball and socket design, there were a lot of similarities with those ball and socket designs, but we've moved on to ProDisc, which has been around for quite some time, but it continues to evolve. And what you're seeing here is they've got, ProDisc C, there's an SK, which is more of a low profile. Why? To basically address patient needs. I believe Geyer et al. Had done a study where he presented this at NAS 2 years ago, where they were looking at cervical discs, and 4 millimeters is actually for disc height, which is quite small and was always difficult to develop in a disc, for instance. But 4 millimeters was kind of that mean disc height that was seen in women in the cervical spine, because we do tend to be smaller, obviously, with respect to our discs and vertebra. They also have a Vivo model and they have a Nova model. But what's interesting is it almost looks like it's, dare I say, modular. Basically, they're developing exactly modular.
No, that's a very good point. It is. Right.
So it's going to address many of the different patients and the nuances and the differences in anatomy. Also, do you want more stability at that level, or do you want more motion at that level? That's what I call patient specific. We've got all this terminology, the sexy terms that I always talk about, right? Oh, patient specificity. These are patient specific implants or patient matched. When you think about, to me, patient specific means, well, tell me about the nuances of that patient. Do they need more mobility at that level, or did you take a severely degenerative disc, you've expanded upon those indications, and you want to maybe stabilize it a bit more, but you can still use an artificial disc. So you may want to use something that's a little more stable. Now, with respect to the lumbar, Charite was the first, as we all know, and there's many lessons learned when we'll talk about that too, when we get into some of the clinical outcomes from that device, with Actival being the later one. Again,
Right.
thinking about the indications and the contraindications, they're one level for those. And mainly that's due to very different anatomical demands
Mhm.
and biomechanical demands, different form and function, cervical versus lumbar. So as a
I've
biomechanist,
heard that phrase before, form and function. You say that a lot.
yes, that's my motto now. I decided. I figured after 20 years, well, probably a little bit more, really studying biomechanics, it really does come down to form and function.
Mhm. Clinically, what are the long-term outcomes, revisions, complications?
With respect to the cervical disc outcomes,
Mhm.
they're very, very good. Looking at one of the publications by Corrick et al., the Simplify disc actually showed superiority over ACDF. 87% of the TDR group versus 77.1% for the ACDF met the criteria or the endpoints of the clinical studies, mainly looking at the NDI scores, et cetera. And so when you think of cervical, they have very high success rates, either equivalent or better than the ACDF. But that was such a great study
Now,
that
Lisa,
showed.
and in that study, can you quickly look, what was the indication? Was the specific indication? Was it just stenosis or spondyle? What was their indication?
This is the indication for, actually for Simplify. I took the
Oh,
most
there we go.
recent indication.
Intractable
Yes,
radiculopathy, arm. There you go. That's it right
ex-
there.
exactly.
Excellent. Okay, super.
So it's the standard because it's part of that IDE study
Yeah.
that you're
Well,
following and the protocols.
exactly. And Lisa, since we're at indications, can you just talk a little bit about indications, especially if you can, as compared to fusion?
Oh, definitely. So these are the indications for cervical EDRs, and then I'll show you the ones for lumbar, obviously. This is kind of standard indicated for use in skeletally mature patients. You see that on the fusion ones as well. Again, for reconstruction of the disc at 1 or 2, and this is because the most recent one, Simplify, was approved for both contiguous levels. That's important. Most of them that have 2 are for contiguous levels, not for having a space between.
Not, yes, not on 1 and 5. No.
Exactly, exactly.
Okay.
That's challenging in itself. That changes the mechanics somewhat,
Yes.
obviously. Um,
No.
and dare I use the word, the hybrid approach, which is becoming more popular where, and it's not approved for hybrid, that's off label, but they're using it to top off a fusion in the hopes of reducing adjacent segment disorder.
Yeah. Mhm.
And so basically these are the indications for the TDR. And again, typical statement here that you'd find in fusion indications, they should have failed at least 6 weeks of non-operative treatment. That's very standard.
Mhm.
Now, when you
Mhm.
look at the contraindications, These are going to differ slightly between companies. The early contraindications may not have had as much contraindications, or they may have had more, but we've learned so much more over the 20 years of what works. So these are the FDA approved indications and contraindications shown on this slide are the contraindications. But what we're seeing is the surgeons make the decision again, heck, I can remove these osteophytes. And if you look at some of this, they talk about severe facet disease, facet degeneration. That makes sense of not being a candidate for TDR, but you start to move into bridging osteophytes. Well, some surgeons can remove them. They can increase the spacing for really collapsed discs, and they're having great success using these artificial TDR devices, excuse me. With respect to the lumbar, here's the indication. Pretty straightforward, with the exception of saying reconstruction of the disc at one level. It's pretty darn similar to fusion in the lumbar spine. The contraindications are
Look at
endless
that.
here. It's a
Yep.
huge list, very specific too, when you think about real definition of unremitting pain with predominance in the leg pain symptoms greater than back pain. Myelopathy, spinal stenosis, that's seen in others. Grade 1 spondy, we see that even in fusion indications, contraindications. Compromised vertebral bodies at the affected level due to trauma. So you're seeing more on those contraindications. Some are similar to the cervical spine, but many are really specific to the loading environment and the stabilization needs for the lumbar spine.
Well, loading is, you said it. I mean, loading is what leads us to adjacent level disease.
Exactly.
Loading is what separates cervical from lumbar. Yes.
That's
Indeed.
perfect. It leads me into
Yes.
this overview.
I always like it when you do the anatomical and biomechanical overviews.
And why is that? Because form follows function. The cervical spine is not the same as the lumbar spine. It's kind of what I learned. I worked for neurosurgery division years ago in Albuquerque, and they had a pediatric neurosurgeon that used to say, children are not small adults. They're different. Well, your cervical spine is very different from your lumbar spine, biomechanically, anatomically. Why? It really comes down to the facet joints. So the facets really determine that degree of motion and the plane of motion at that level. So we know that cervical facets are coronally oriented, and they have an angle of about 45 degrees in the sagittal plane, but the lumbar spine has a little bit of coronal, but as you can see, 90 degrees, it's mainly a sagittal plane facet. So what does that mean? Well, it means that it's easier for the lumbar spine to slip. Again, form and function. If we have a slip of our facets in the cervical spine, it's far more detrimental. In the lumbar spine, where your spinal cord ends at about L1, L2, you've got nerve roots. Yes, it's going to cause some pain, but it's less risk to permanent paralysis. Again, cervical spine, stability versus mobility. Cervical spine has greater mobility, less stability, meaning less than the lumbar spine. The lumbar spine is designed for more stability, less mobility. Again, you look at the axial load tolerances, obviously the lumbar spine, it's bigger, it's designed to be bigger to take up more load, distribute the force over a greater area, less stress, localized stress risers. Shock absorbent is going to be greater in the lumbar spine because of the thicker discs. And you can see in the cervical spine, the range of motion is greater than that in the lumbar spine. I had to show this picture because these are, again, this dates me. These are Dr. Rauschning's cryo sections. These were early on, but they're beautiful. To me, as weird as this sounds, it is a work of art. His sections were spectacular, but they show that anatomy. And so what I tried to do is kind of draw out the angles we're talking about. Again, cervical spine is a coronal facet joint. And you're in the sagittal plane at about 45 degrees angulation. In the lumbar spine, those facet joints are at about 90 degrees in that sagittal plane. And you have some,
That
I don't know.
that's a great
So,
slide. I agree. Good
and
stuff.
it's beautiful because you look at it and you go, oh, I get it. It makes sense now. So,
That's wonderful. So, I know I'm going to switch gears on you kind of abruptly. Sorry. Uh,
no, that's fine.
but the other story about these discs over 20 years has been the issue with the regulatory landscape. Not just regulatory, but you might also say reimbursement. And the two, kind of go hand in hand, actually. So let's just start with regulatory, PMAs, class three, that sort of thing. What is the landscape for these motion
They,
preserving devices?
they are class 3 devices. That means
Mhm.
they are PMAs. You have to do clinical studies, and you have to do more if you, in the cervical spine, want 2 levels. So you'd have a 1-level arm and a 2-level arm to your study. They take many years, as we all know, and 20, 30, 40, $50 million. Again, I've heard horror stories of more than that as a cost, but usually 20, 30 million is probably the starting
That's
point,
right. That's right.
in many years. And again, if you're going to do the early clinical studies, at least for cervical, we're non-inferiority. You're just equivalent to ACDF. Then I think they changed where you could compare to other cervical arthroplasty devices, the TDRs, that have been approved as well. And then in lumbar, again, it's the same pathway. And I think the last approval, like I said, for lumbar was 2015. So we haven't progressed much in lumbar.
Been a while. Well, and again, we called this, it's been 20 years since Charite, because that was the sort of the landmark uh, uh lumbar total disc arthroplasty. It came to the market with a lot of fanfare, and it came with, Johnson and Johnson brought it to market. It's kind of a great big deal, and it's gone now. So I guess that leads me to the next question that our audience sent to us. As you've done this survey of these discs and reviewed the literature and reviewed all these things, which disc, cervical or lumbar, and how many levels have been the most clinically successful over these 2 decades?
That's a great question. I've got some pictures. I want to give you a little bit of background, and then we can talk about, even in the lumbar spine, the long-term outcomes. So I had given many motion preservation talks, and I had one on TDRs. Mainly it was for cervical, but a lot of these principles also apply to the lumbar discs that are out there, obviously similar in design. We have different classifications, and so I broke it down into a number of different classifications to better understand, do they really differ? That's always that question, how much do they differ? Well, they do differ. I've basically broken down the TDRs into biomechanical classifications. And a lot of this work was also done by, Dr. Pat Warden has publications on discs. He's done so much work in this area. But the 3 types are the constrained, the semi-constrained, and the unconstrained. Now that's basically the first layer of differences in the designs of these devices. So when you look at the constrained, it's a mode of motion that includes a mechanical stop within a normal physiological range of motion. But it limits the number of the degrees of freedom in that motion in 3D space. Degrees of freedom, from other lectures, as you know, is the motion about the 3 planes, anatomical planes. So coronal, sagittal, and medial lateral. Semi-constrained is a mode of motion that includes a mechanical stop outside the normal physiological range of motion, so that you can go beyond the physiological range of motion. You've opened that up a bit more. So when you think about that, the semi-constrained may have more mobility, where the constrained may have more stability or provide more stability. And then there's the unconstrained, where it has no mechanical stop. It can move independent motion in all three orthogonal axes, anatomical axes. There's also the next level where you've got 3-component TDRs, 2-component TDRs, and the next slide, you'll see elastomeric, right? 3-component has 2 articulating bearing joints. So you've got 2 joints that move about each other, where you can kind of split up your planes of motion, but you have 5 degrees of freedom. Why is that? Well, because you've got this incompressible biconvex core that sits between the 2 end plates. The 2-component TDR can have different degrees of freedom based on this traditional ball and socket joint. It's a spherical bearing joint. You have an incompressible biconvex core again, so you're not going to have compression or tension, but you're limited as well and only have 3 degrees of freedom, where you're getting flexion, extension, lateral bending, and axial rotation, but no translation. You're kind of fixing that translation, where the 3-component gives you that translational part of it. And then you've got your non-articulating TDR, but they do have 6 degrees of freedom. Why? Because you're adding that compression and tension component to that disc. You receive like the Bryan disc that was out and the M6 disc. That tension component is the outer sheath, for instance. It's compliant, as well as the core being compliant, so it'll compress. And that's where the 6 degrees of freedom comes from. But when you compare a lot of these, now this is early work, so I don't have the M6 or Simplify on this, but when you look at the Bryan disc, which is 6 degrees of freedom, versus a Pro disc, Prestige, Cervicor, you have the many differences with these different designs. They seem like small nuances, but they really do make a different type of impact on the level. It can change the mechanics. The first biggest change you see is the center of rotation. That's key here. If that center of rotation, based on the design, is different in location for each of these discs, you have different bearing shapes, and that changes the different bearing concerns, meaning that shape changes how it moves, also the range of motion that can be obtained with that shape, as well as, are you going to have more debris? Again, then you've got the material that plays into that differs. That affects your debris as well, your wear debris. So you can see the different designs and how they could change mobility versus stability, both for cervical and lumbar.
And do you think there'd be a difference in sort of the wear debris, whether it's cervical or lumbar?
Yes, definitely. And again, remember, lumbar has greater forces. Now, it's a double-edged sword there, because more force could cause it to bind, heterotopic ossification.
And to be clear, I haven't heard that wear debris is an issue. I mean, that hasn't come up a lot. Have you seen anything that indicates that that's something people worry about?
No, well, it's always something people worry about, as does the FDA.
Sure.
Hip and knee implants have 10 to 15 times more wear than spinal implants. And that's for comparing it to lumbar. This is the early work on the cervical discs. And you're looking at metal on metal hips versus metal on poly hips, which has the most. Now, there's newer technologies out there from a measurement standpoint and ways to get device related particulate. In the early days of the Bryan and the Prestige, we didn't have the sophisticated equipment, where, computer automated software that can pick out that particulate, the AI capabilities, obviously, that can pull out nanoparticulate as well, which has been the big issue. And we've really progressed and really look at truly device related. So that's why I'm saying it's probably somewhat inflated because of the measurements that were made early on. And what happens is when you're running these tests, you get obviously debris from the fixtures, which can be metallic or polymeric as well, and that's all kind of bundled into that. But it's a huge difference between what we see in hips and knees and what's considered a safe level on hips
Again,
and knees.
and may I bring forth the form and function argument yet again? Form
Yes,
function of a
please.
hip is not form and function for the cervical disc. Form and function of the knee, not the form and function of the lumbar disc. Just saying.
Oh, exactly. Exactly. Perfect
So,
example.
well, I'm learning. I'm learning. I listen. Um, so we've got some innovation doesn't stop. The march of innovation, it just keeps moving forward. And I'm thinking here in about three spine and three spine, which has just been such an exciting young company with really innovative ideas. They address the facet joints as well. In your opinion, how strong is the need to address the facet joints when you're doing a total disc arthroplasty? And again, as being proposed by Three Spine and probably other companies too.
That's an interesting question because you've got we talk about anterior and posterior column support. Anterior column takes up about 80% of the axial loads, posterior about 20. The concern I have, and again, there's a lot of new innovation coming out, but the concern I have is competing implants. So one, we know that if the facets are arthritic, if they're fused, the patient is most likely not a candidate, cervical or lumbar, not a candidate for a TDR. I think that in the latest paper, the 20 years out, published by Geyer et al., the TBI group, fabulous paper. They talk about really, opening up those indications, but they stop at facet fusion and autofusion of the vertebral body. But when you think about fixing or treating the facets, are you talking about keeping them mobile as well? So the way I interpret that is, are you saying you'd have a disc and then a mobile facet implant? Now that's where I get nervous as a biomechanist, because if you link the facets, you can have issues, because even on the same level, spinal level, the facets are not the same. One may be angled different from the other. Now you've changed your loading, you've changed your stress pattern. So if you're trying, and then you've got a cervical disc. Now, the other part of this is mismatched moduli or mismatched motion. So you're trying to control so much of that motion at that level. By doing so, you could be creating many more adverse effects along the spine. You want to go in, help the tissue, like a crutch aids walking. Don't overtake it. When you start to overtake it, that's when things fail. And that's my concern. If you're going to go anterior and posterior column, and you want to make a posterior device, you might have the disc, but to try to really replicate that, I don't know if our technology, with what we have with respect to materials, if we're there yet. I think we're getting closer, but we have so much we can do between printing and printing tissue and
That's right.
I think we can get there, but it would be great if we could do it in a more biological manner.
So when 20 years ago when the Charite was approved and we had the Pro Disc on the horizon and things were really starting to just accelerate. There was just an explosion. It was a very exciting time. Here we are 20 years later. I would hazard to say that these motion preserving devices have not yet reached what the clinical data would say is their potential. So in your judgment, what have been some of the hurdles to get adoption going? It's certainly in the United States for these devices.
I think one more perspective, I think it's potentially harder. One, because it's a single level. Two, because the main job of the lumbar spine is stabilization. And I know I've kind of made it very generic, either it's motion or stability, but the lumbar spine sees much higher loads. You need to maintain that stability. And if you open it up to motion, and again, you expand those indications where you're saying, okay, I can get in, here's a collapsed disc. I'll make a wider space, remove the osteophytes, but I'll have more mobility. It's that question of, well, how much is too much? Because of the higher loads and higher stresses, it's going to change at a faster rate. And I think that that's part of the problem, and the fact that, again, you saw the contraindications. That list of
Mhm.
contraindications is lengthy.
And you're referring to lumbar. I mean,
I'm referring
lumbar
to lumbar.
has had more challenges, and I think those who've been in using disc arthroplasty for a number of years, they're fighting with the reimbursement agencies. It's a struggle. Even
Yes,
when the surgeon thinks in their best medical judgment that for this particular patient, this is the right treatment, it's fighting the battle with the reimbursement with the insurance.
exactly.
Now, cervical, not so tough. In your opinion, are we still kind of under penetrating? Are there still patients out there that for one reason or another who could use or should get motion preservation in the neck still struggling?
I think less so for cervical, because there's
Mhm.
more out there. The long-term results are wonderful. And that's consistent with all of the studies conducted for all 15 of those implants. And the insurance agencies are a little more amenable for reimbursement for these patients. And it spans between young and old. Again, there's a number of different designs out there to accommodate motion versus stability for the cervical spine. So it's been much more successful because it's been adopted at a faster rate, certainly, than lumbar. I think the 20-year landmark paper, though, by the Texas Back Group is phenomenal, because I found that they had an incredibly low rate of revisions and removal out of 2,141 patients, and I'm just kind of quoting it from their paper.
Mhm, mhm.
1.26%, 1.3%.
Oh my gosh.
It's
Unbel-
unbelievable.
It's in- it's fun. I mean, this is phenomenal data.
It is phenomenal, and it's a 20-year study. It was
Mhm.
performed by multiple surgeons within Texas Back Institute. And it's wonderful because they attribute a lot of that 1.26% revision removals to the early learning curve early on, because it did have a higher learning curve. But to have a 1.26% revision rate and removal out of 2,000 patients, greater than 2,000,
Fantastic. That's
is
fantastic.
amazing.
Yep,
And again,
it sure
we
is.
look at hip and knees, you know, you're looking at much higher, hips are 15%
Mhm,
revision rates, knees are 10% revision
mhm,
removal,
mhm.
which is pretty high.
That really is. Those are super numbers, Lisa. we're getting kind of near the end of our time, so I want to. You talked earlier a little bit about materials, and it seems to me that over the 20 years, again, innovation will not be denied. A lot of interesting new innovation in terms of surface technologies, in terms of some of these designs and materials. Uh, as you've surveyed the area in your mind, what is new uh, after all this time in design and material and technologies?
I think we're taking baby steps with respect to what is new. There's not these huge leaps. Now, additive manufacturing has changed the industry
Mhm.
for fixation of these TDRs to the end plates. You can print open architectures that will have faster osseointegration into that end plate to hold that in place. So that has changed, but it's been around for a while. We've got, folks using, again, I'm using the Simplify as the example here, polymers, peak end plates for imaging purposes and a ceramic core for low wear. Again, wear's not a huge issue though. We're not seeing a whole lot here at
Mhm.
all.
Not a huge issue.
At all. And
No.
that goes for lumbar too. And lumbar would
Mhm.
be expected to have greater wear because it's a bigger disc, bigger sliding surface
Mhm.
when you're looking at the TDRs. And so the imaging capabilities are
So,
better
so let
with
me,
the,
yeah. So here's the acid test question. Are these still investigational devices?
no, they're approved. Uh,
Too many agreed. More than a few reimbursing agencies, companies still say they're investigational devices.
I know. Uh, Reimbursement is an interesting
So maybe
field.
these aren't rational actors. Maybe they're doing it for other reasons. Because the data, as you've been pointing out really nicely here at our master class, the data, 20-year data was, I'm sorry, 10-year data, or is that 20-year data from Texas
Well,
back?
for cervicals 10 and 15, and then from what I've seen,
I mean,
and 20
come
for
on,
lumbar.
give me a break.
It's, yeah, exactly.
The reoperation rate is the lowest of all the articulating joints. We have long-term data.
I wonder, well, let me ask you, what are your thoughts as to why there's differences reimbursement? I've got different thoughts with respect to, there's always the insurance side, because it's not in sync, it's not aligned with, the FDA says it's approved, it's good, the clinical says great. The publications and the outcomes years later say they're working fabulously. But the insurance companies, they've always lagged, but this is a significant lag.
This is a significant lag. We're not talking about a couple of years.
No,
We're talking about a
exactly,
decade.
exactly. And I always
So,
wonder, all right,
so
additional factors.
there is literally no excuse other than I want more profits. There
Well,
there's
yeah, yes,
if the if the core objective is to do better by way of the patient, the policyholder, incidentally, you follow the data. And if you don't think you have enough data, wait longer and do more follow-up. But here you've
right.
got 10,
You've got the
15-year follow-up,
data.
top institution, and
Exactly,
multiple investigators.
exactly. I used to think it was, okay, did somebody, when I say somebody, company, whoever, certain, did somebody behave badly? And then that stigma stays, but that's not it.
Yeah. Well,
It's,
I can, yeah, that's true. And by the way, we do need to wrap this up. So we wrote my last comment, I promise. It could well be, again, let's go back to Charite. So the Charite came out, you had a rush of enthusiasm, you had Charites implanted, you had Charites revised and explanted, and there were some problems. And that may well be that 20-year-old experience may well be sort of somehow sticking in the minds of some folks at some reimbursing agencies. But anyway, that's
Yeah,
who knows? Who knows?
it's
Today's a new day. We have better data now.
and it's always a constant struggle with the insurance companies because I would agree with you with the profits. I mean, we spend years paying for our health insurance and other insurance, and when you need it, there's always it needs to be, at 2 p.m. on a Wednesday at this under this specific ridiculous criteria to get in to,
Tom,
file the
Tom
claim and get
Kirk,
it.
Dom Kirk, who is one of the giants of the research scientist surgeon, who is just a model for everyone, said once, health insurance companies are organized to take care of the healthy patient.
Mm-hmm, exactly. Because
And the
it doesn't
rest of us
cost
think
them.
the rest of us think they're organized to take care of the sick or injured patient.
No, not at
Yeah.
all.
Lisa, as always, you have the answers for everything, and you have slides to back it up. And I have to say that it is form and function epitomized. So I thank you again for another really great masterclass. I know I learned a lot. I hope our audience did too. And of course, most of all, thank you to you, our audience, because if you didn't send in questions, Lisa and I would just compare, summer vacation slides. So
Yes.
thank you very much.
Thank
All
you.
right.
And I thank the audience.
Absolutely. And I think that's our end of this masterclass. And I look forward to our live masterclass at NAS on the subject of
Yes,
SI joint fusion, which should be very
me too.
exciting.
Thank you, Robin. Thanks, everybody. Take care.
Have a good night.
See you. You too.